So just like on studying for the renal diseases, the case studies for tomorrow, use the chart from that study guide. On these, you'll want to use the chart. What's the defect? What's the key finding? Okay? So they're on chapter 3 in one book, and I want to get my other book out too. Get everything in order that I want. I have them in the PowerPoint, but they're hard to see unless you're on the computer. So I copied the pathways that are affected, and I ended up just doing. You want to start passing them around. So what I have on here is the tyrosine pathway. I have the tryptophan pathway. I have the degradation of heme pathway. And I have the ferric chloride is a common screening test for aminoacidosis. So I just tried to copy it from the from your book so that you, because a lot of you I'm sure don't read your you don't read your PowerPoints from your screen.
I didn't get the second one.
I'm sorry, what?
I was saying I didn't get the second one.
Yeah, there's two different ones. There's two different ones.
There's two separate ones. So this should help you to see where the defect is. When they're amino acid, and this is for test 5, so both of these are test 4, which is week 5. So both of these put test 4, week 5. The PowerPoint is test 4, week 5. It has nothing to do with tomorrow's test. It probably won't be a real long test because we're going to start body fluids tomorrow in lecture. And that should be very familiar for you with just having heme as far as the calculations. So you already on test 4 will have this PowerPoint, and then you're going to get calculations. So because you got to know how to use that formula with or without dilution. So your test 5 might not be a full test. I don't know if it'll be 75 points. Or your test 4, I'm sorry, I keep saying test 5. So what you want to do as we go through, I'll flag which pathway you want to look at. So right away, the pathway you want to look at is the phenylalanine pathway, okay? Because I think if you understand where the defect is, it helps you to understand the disease state. And you need to know the key finding. What is the defect and what is the key finding? Most of these defects are genetic. They call them inborn errors of metabolism. Usually you're missing an enzyme that helps the amino acid completely metabolize properly. If you miss that enzyme, products build up because they can't follow the completion of the pathway. There's one disease state that is actually the kidneys the problem, why you have it spilling over. So you're going to have to know if there's a key enzyme that I want you to know, I'll flag it. If it's the kidney is the defect, I'll flag it. But that's the kind of thing you're going to have to know for your test. What goes with each amino acid problem? And if there's a key finding, what makes it stand out? Because like, for instance, the blue baby diaper syndrome we'll get to. That's a big deal. The moms would notice when they changed the baby's diaper, it was blue from this spillage from the tryptophan pathway. So we're going to try to associate key findings with each one. You should be able to tell me with the porphyria. We've already talked about it when we talked about colors of urine. Anybody remember with the porphyria, what was the color you'd see of your urine?
Orange.
We're going to get to black ones. That was pyridium. It's port wine. And they give that as a clue on the registry test. You see a port wine red urine, you should be thinking porphyrias, and the most common one we're going to know about is lead poisoning. And you'll see on the heme pathway where it affects it. There's other porphyrias. We're going to key into the key one. So remember, try to study that table from the study guide because it breaks it into key findings and defects. You know, will you see many of these? I've never ever seen the PKU results when I worked at St. E's come back. I'd see the little heel stick that we sent out, but I'd never see the results when they came back. So I don't know if you'll ever know an aminoaciduria at your lab, especially if they send them out. So as we go, and on the carbohydrate disorders that are at the end of the PowerPoint, you should be able to tell me on your analysis how we detect a reducing substance or another sugar. How do you do that? What's the dipstick check for, and what's the confirming test check for of the only sugar on the dipstick?
Clinitose.
Glucose. So if I have a reducing substance other than glucose, what are you going to see on the dipstick and what are you going to see in the clinitest?
Positive clinitose.
Sick and positive on the clinitest. So then the doctor has to figure, hey, we got to look at other sugars. Maybe there's another carbohydrate that like lactose, galactose. So take what you already know and build on it. We as techs don't always know the history of the patient. We might get a little blurb that comes in across the computer, but it may not be actually what the problem is once they get them in for real. If they don't update it, you don't really have that to go by. Yes?
So on the clinic test, when it tests positive for galactose and all the others?
Our lactose,
Yeah. So does that mean that the body can't process?
it just doesn't utilize that sugar. And babies, how many babies have to switch formula after formula after formula because they have a problem with processing it? And they go to what, soy? My daughter was telling me there's even another one out there now in case they can't handle even the other things like soy. So think of that test as a big indicator, just a urine for a physician on newborns if they can't handle.
If the dipstick is negative on glucose, do you automatically do the clinic test?
It'll vary on your lab. Our protocol was any child under 2 years old. I heard they're getting away from confirming tests. But that was when we used it at St. E's. Any child under 2 and any labor mom we had to. But I don't know if anybody does that anymore. That was our protocol. When I left there, we were at least doing clinic tests. They were telling me now they're getting away from all of them. Okay, so the inborn error of metabolism. Usually it's inherited autosomal recessive, and it's usually some enzyme defect in the pathway. If you see all these bolded on the handouts I gave you, usually it looks like they bolded what builds up because of the defect. So we're gonna key into set ones. 2 of them are not going to be any kind of defect that you're born without an enzyme. 2 of them are going to be from cancers. One's going to be melaninuria, if you see that pathway on the phenylalanine. If you have a tumor, you're going to have extra products produced because this tumor keeps producing them. And there's one called 5-HIAA we're going to get to in the tryptophan pathway. It is cancer of cells in the intestine called argentaphin cells. And you'll excrete this 5-HIAA, which I won't make you know the long name for it, but at least those are related, not anything to do with a genetic defect. They have a cancer that you have that triggers the production of it. So you got to think what causes it. And it could be a cancer, it could be a defect, you're missing an enzyme, or it could be a kidney problem. So you should be able to tell me on the ones I flag, which is the defect. Some of them you're going to have to tell me what enzyme is missing, and we'll flag that. And then if there's a key symptom that I want you to know. So PKU naturally is going to be a big one. That is probably the most common one they test for in newborns within 5 days. But it's inborn error of metabolism, you have a genetic defect. And you're missing some enzyme in the pathway. If it says a renal problem, then it's usually the kidney is the problem. There's no defect in any pathway. So just keep that in mind. So the overflow type goes with a defect genetically. And they call them inborn error metabolism. So that's just something that is associated with aminoacidureas. The renotype, and we only have one, cystinuria, the defect is in the kidney. You have no problem with your metabolizing these amino acids. The kidney can't process it right. And you'll see when we get to cysteine, there's a few of them. Cystinuria. So if you want to write here, cystinuria, at least every time you go through something, you'll see it over and over. PKU is a key one. That's an inborn error of metabolism you are missing. And I think you've already had this. Do you know an enzyme you're missing? I thought Barb was talking about PKU one day when I was around. Phenylalanine hydroxylase. Okay, so you have your tyrosine pathway out. Phenylalanine tyrosine pathway. That's the one I gave you on the top. So this is pretty common for aminoacidureas. 1 in 10,000 to 20,000 births. Phenylalanine is found in milk. Usually it's phenylalanine to tyrosine is the pathway that normally happens. And it's your first one. And I think I might put the colored picture up on the Elmo. So you have to know you are missing the gene to produce the enzyme phenylalanine hydroxylase. You got to know PKU. So you not only have to know it's an inborn error of metabolism, it's a genetic defect, you got to know the enzyme it's missing. And they say the diapers can smell kind of musty, mousy, and if it's undetected, mental retardation usually occurs. There's a test, anything I have bolded, you need to know. They call it the Guthrie test. What they have on it is a bacteria called Bacillus subtilis. Did you do that? If you took anatomies here, I thought that was one of the bugs they used. It's a gram-positive bacilli, and it's normal flora, so it's not harmful, and it's called Bacillus subtilis. We'll talk about Bacillus anthracis and Bacillus cereus, but Bacillus subtilis is usually nothing bad. Well, they have found if excess phenylalanine is in your urine or the blood, when you do the heel stick, it'll cause the Bacillus subtilis on whatever they put the blood on to grow. And this bacteria will grow, and they know there's excess phenylalanine. It's not getting processed right. So let's look at that pathway. I'll put the colored one on the board from the book where I copied it from. So normally, let me turn the light up, make it look a little better. There's a lot happening in that pathway. So normally, it processes through to tyrosine. But if you're missing phenylalanine hydroxylase, it ends up going out as phenylpyruvic acid. It can't complete it straight down the middle area like it normally would. So you've got to know, if it helps you on the chart, to write PKU by this and circle phenylalanine hydroxylase is what is missing. And then phenylketonuria occurs and this phenylpyruvic acid builds up in the urine. And the test you have to know, I want you to know the Guthrie test. And you need to know Bacillus subtilis will grow when there's excess in the urine or serum.
So we do that test for the phenol.
Yep, for
Yeah.
PKU. let's see, this one might explain it pretty good. PKU, it says, thought this one would be the best one. It just says excess levels of phenylalanine in the blood will cause brain damage resulting in severe retardation. Other characteristics, lighter skin, hair color, seizures, susceptibility to eczema. Patients with PKU appear normal at birth, become severely afflicted by age 1. Yeah, this, usually we'll see if, that's from graph. I would think this one would talk about it. Let's see, this one it says, the initial screening for PKU does not come under the auspices of urinalysis laboratory because increased blood levels of phenylalanine must of course occur before urinary excretion of phenylpyruvic acid, which may take 2 to 6 weeks. State laws require that blood be collected after 24 hours after birth and before the release of the patient from the hospital. Our old edition used to explain it. Yeah, my newer edition doesn't explain it in either one. But just know that PKU, you gotta know the Guthrie test. And you need to know the bacteria. So, the key things to know, it's the most common one. It is missing the enzyme phenylalanine hydroxylase. That's the inborn error of metabolism, so it's a genetic defect. This is what it's missing. Phenylalanine can build up in the blood. Phenylpyruvic acid on that chart can fill up in the urine, and it causes mental retardation if left untreated. Usually they do dietary changes as the treatment. That's why they want to know right away at birth. And you avoid, if phenylalanine is something in milk, then naturally you're going to look for something else to give them besides milk or any milk product. And a screening test is called the Guthrie and Bacillus subtilis. When you expose it to the urine or the blood, will grow if you have excess the phenylpyruvic acid or the phenylalanine. So remember, if there's excess of phenylalanine or the phenylpyruvic acid, the Bacillus subtilis will grow. If you process your phenylalanine normally, it's not going to grow. You're going to get no growth. And you'll understand that more when we get to micro, when you see growth versus no growth on your plates. This is probably your most common aminoacidureas. And what else you have to know is what's the pathway. The pathway is phenylalanine tyrosine. So that's the first graph you have. That's going to be your most common one. So it's the PKU. And if you just kind of like we said, what's a common false negative or urine ascorbic acid? You would say, what's a common treatment for aminoacidureas? Dietary changes. What's a common disease? Mental retardation. So they kind of have a common theme. These, the two big ones I want you to know are going to be alkaptonuria, I would star, and melaninuria. What do you already know about them when we discuss color of the urine? They darken upon standing. They go to black, black-brown. Those are two. If you don't know anything else about those two, You gotta know that urine darkens upon standing. So there's alkaptonuria and melaninuria. So if you still got your pathway out, you see on where it flags alkaptonuria. You see where excessive melanin is over here. And you see alkaptonuria. That's one we're going to have to also know the enzyme. We're gonna circle that one. So on tyrosinluria, you don't have to know anything from me for the test. Excess tyrosine accumulates in urine. You need the liver to function normally to metabolize tyrosine completely. So sometimes premature infants or people who have severe liver disease, they're going to have excess tyrosine back up in their urine because their liver can't process it. Okay? So you don't have to know that one for the test. These two you got to know for your test. Alkaptonuria, if you see on the pathway, it's flagged. You have phenylalanine goes to tyrosine, goes to p-hydroxyphenylpyruvic acid. Then you see where it hits homogentisic acid. And you see where it's flagged alkaptonuria. I would circle that. So you know you want to circle phenylketonuria. You know you want to circle alkaptonuria. This one you're going to need to know it's an inborn error of metabolism. It's genetically missing an enzyme. So the enzyme, and I should have kept that up because it's the same pathway. Phenylalanine tyrosine pathway. That's the pathway. The enzyme it's missing, though, underline that, homogentisic acid oxidase. It's an inborn error of metabolism. It's not a kidney problem. You're genetically deficient in the capability of making this enzyme. And the key finding is what we talked about. Urine darkens upon standing. So the longer it sits at room temp, it goes dark brown, black looking. That's the key finding. And they call it alkaptonuria. So if I asked you on a test, what pathway does alkaptonuria belong to? You'd say phenylalanine tyrosine. I asked you if it's a genetic defect, inborn error metabolism, or a kidney problem. It's a genetic defect. And that one you do have to know the enzyme. So far you have to know two enzymes that are defective. PKU's enzyme and that one. But the big clue is the urine darkens upon standing. So the only reason I want you to know melaninuria, you see on your pathway where melanin is the blue, yours would be blue box, but you see where it goes tyrosine and an arrow goes over to the melanin. When you have a tumor, like in melanoma, you're going to have overproduction of that melanin. So you need to know, this is the first one that's triggered by a cancer. In melaninuria, it's overproduction of melanin because you have melanoma. So it's our first one that's caused by cancer. So would the defect be genetic defect? No. Would it be urine, the kidney doesn't work? No. It's triggered by a cancer. So this is one of two you got to know by a cancer. You don't have to know it's overproduction of melanin. Due to melanoma. So this is our first cancer. So if I ask you what pathway was PKU, phenylalanine tyrosine. What pathway was alkaptonuria? Phenylalanine tyrosine. What pathway was melanuria? Because of a cancer, phenylalanine. So they're the same pathway affected, but two different causes. Two of them are genetic inborn errors of metabolism, and one of them is due to a cancer. Okay, that's how I want you to kind of study, and I think your study guide is in chart form. So the study guide keys are good for tomorrow's test and good for test 4 next week. Now, I don't have a pathway for the maple syrup urine disease. All I want you to know about this amino acid, there's 3 of them that are defective. They're called branch chain amino acid disorders, and you need to know these 3. So the maple syrup urine disease, you have to know what pathway or what amino acids are affected. So you would have to know, so maple syrup urine disease, leucine, isoleucine, and valine. And what else do you think might be a clue when you collect the urine that I want you to know? By its name. What do you think it smells like? Maple syrup. So the odor could be a clue in the baby's diaper if it had a maple syrup smell. So this is all I want you to know about branch chain. What 3 amino acids are affected, and odor ends up being a big clue. Once again, dietary changes, mental retardation are a big problem with these disorders. Okay, so you have maple syrup, urine disease, and it's leucine, isoleucine, and valine. Usually after 1 week they have failure to thrive. They're not developing properly. Now this is the one that we're going to run into the kidney problem. And that's the big thing I want you to know is cystinuria. So on this page, I want you to circle cystinuria. I'm not going to make you know cystinosis. I'm not going to make you know homocystinuria for your test. But all of these 2 involve a problem with cysteine. There's an amino acid called methionine, that homocystinuria. But you're not going to have to know that for the test. But this one I want to flag, because this is the only one where the kidney, it's the renal type. Remember the inborn error of metabolisms, they call them the overflow type. You can't genetically make an enzyme that is needed in the pathway, so they overflow the metabolites into the urine. That's why they call them the overflow type. This is your only renal type, so make a big note, renal type. And what you want to circle is the inability of the tubules to reabsorb. And it's not just cysteine, but we're just going to circle through cysteine. You don't have to know lysine, arginine, or ornithine. It affects them too. I'm just going to have you circle through cysteine. And that's the big key. It is not a problem with the metabolism of cysteine, it's the problem of the kidney. Can't reabsorb. Remember, where are amino acids reabsorbed actively? You just had a test on that. Where should they be reabsorbed? In the proximal tubule. Remember, glucose, amino acids, sodium chloride. And they can't. The kidney's defective. So cystinuria is the only one on this page I'm going to test you on. And the cysteine, anybody remember what shape the cysteine crystals are for tomorrow? 6. And they can form renal calculi and form kidney stones. Okay? So this is the only one on this page you have to know for test 4. There's a cystinosis, which is a genetic defect in the metabolism of cysteine. It has a lysosomal storage disorder. There's a defect in transporting cysteine, so excess cysteine damages the renal tubule. So it ends up causing a kidney problem. This is the main one that already is because of a kidney problem. Homocystinuria is another amino acid that's defective, the metabolism methionine. And there's homocysteine that can increase in the urine as a metabolite. So those two you don't have to know for me. This is the big one because it's the renal defect. And the amino acid affected is cysteine. That's the main one. I'm not going to worry about you knowing lysine, arginine, or ornithine. So look at your pathway of this one, the heme degradation. We're going to go back to your other one as well when we get to tryptophan. So you need to, the Strassenger is the best pathways versus graph. On the heme degradation, I'll put on the one that you have as a handout, and I'll put it up with color. In the degradation, or basically the formation of heme, I'm sorry, not the degradation, look at all the steps that are involved. Glycine, succinyl-CoA, delta aminolevulinic acid, ALA. You should have heard about that in hematology with lead poisoning. Porphobilinogen, hydroxymethylaldehyde, uroporphyrinogen, coproporphyrinogen, protoporphyrin, and what's part of your hemoglobin molecule? Your iron, your protoporphyrin ring, and your globin. Okay, so this is the formation of the protoporphyrin ring. If you mess up any one of these steps, so look at the enzyme needed. Aminolevulinic acid synthase, aminolevulinic acid synthetase. If you're exposed to lead, this is missing and you develop a porphyria. And what is your big clue you need to know? So the only one I'm going to ask you about is lead poisoning. It is an example of a porphyria. But do you see that whole chart? You can have multiple different porphyrias based on which step you were missing and you were defective genetically. So the only one you have to know, and this should help you relate to the lead poisoning, is the delta, and then the ALA is, that enzyme is missing. So they're missing the aminolevulinic acid synthetase. So I would circle that, and it's lead exposure. And the other key thing I want you to know, I just want you to know it's missing that aminolevulinic acid synthetase.
So if it's missing that marker, we're going to get lead poisoning, and that causes.
And you're going to get the porphyria. So what is your big clue as a tech? What is your only, would be the red port wine. It's like, think of a deep glass of red wine as the color of the urine. So we've already learned of 3 that the color is you as a tech's clue, because you might not know anything else going on with them. So we already said 2, urine darkens upon standing. We have alkaptonuria and we have melanuria. Now we have red port wine urine. You're thinking of porphyria. Something in the formation of heme is out of whack. We're just going to choose higher up in the formation with lead poisoning. But every one of those enzymes along there, if they're defective, you're going to have that byproduct build up. So what you have to know is an example of a porphyria is lead poisoning. What is it missing? Delta, you can say ALA synthetase. That's fine by me. And the big clue, so if I ask a short answer question, give me an example of a cause of a red port wine urine. Lead poisoning, a porphyria. If I asked you a question, what are 2 amino acid disorders that urine darkens upon standing, is your big clue? Melanuria and alkaptonuria. At least you got to be aware. Sometimes those 2 clues are what they give you on the registry, and then you know it because you know it's one of those 2 and the urine darkens upon standing, and you know it's a porphyria. Usually they'll use lead poisoning, because that's something you will see, especially in poor areas that have had lead-based paint. I got to work a little short time in East St. Louis. They had this, probably the nicest office I've ever been to. My whole time was this building in East St. Louis down by the bridge. It was, I guess, probably where our East St. Louis campus is. And I would do their QC for them on all their lead testing on all young children. Because if you live in an area that had leaded paint, and they do anything with eating paint chips or things off the wall, they can get lead poisoning, and it was a big deal. And it was run by the SIUE nursing department. So, and you already know what you test from can be confirming tests for some of the heme degradation or heme formation byproducts. You did them for urobilinogen. What were the two confirming tests?
The 3%.
Watson-Schwartz, and that's protein. Watson-Schwartz and Hesch. Hesch was the one for porphobilinogen. So, what I want you to try to do is, when you look at your study guide key, and I think I already have that one up, and I already have all week's stuff up. I already have the body fluid study guide up. Key. Try to find key things, because you're not going to see amino acid problems commonly, and you may never get to see the results. But you may see the urine that darkens upon standing. You may see the port wine red urine. You may just never get to see the final testing of them. Okay? So you have to at least know what would trigger you to think it might be one. And actually, who's your primary patient going to be? In a lot of cases, the newborn. In the lead poisoning, it could be probably more young children. But most of the amino acid problems you start seeing as in the newborn when they're first born. Okay, there's the hemosynthesis. So we're going to go to the tryptophan ones. Look at your pathway for tryptophan. Normally, if you look down the center of it, tryptophan becomes indole and then is excreted in your feces. But there's two cases. One is called Hartnupp's disease. If you want to, the one that says indigo blue, underneath it put Hartnupp's disease, HARTNUP''S. And then the other one where you want to circle the 5-HIAA at the bottom, that is the other cancer. So what was your first cancer? Melanoma, so you had excess melanin being spilled out into your urine from the tyrosine phenylalanine pathway. So this is the amino acid tryptophan. So if I asked, where does Hartnupp's disease, what pathway does it affect? You would say the tryptophan. If I asked what pathway is the 5-HIAA from, you would say tryptophan. Okay, so the ones I flagged, you've got to know the pathways. So we had what for tyrosine phenylalanine? PKU, melanuria, and alkaptonuria. Okay, then now we have two from the tryptophan. We have the blue baby diaper syndrome, and that's what you'll see sometimes in the questions. It'll flag blue baby diaper syndrome, and that's the clue to the mom. She changes the diaper and it turns blue as the urine is exposed to air. If they have you see what happens when you have an intestinal disorder, you have excess indole, reabsorbed from the intestine into the bloodstream, goes into the liver, becomes indican, and when its indican is exposed to air, it does the blue color. So on this pathway, you want to have that written. Okay, Hartnupp's disease. 5-HIAA is the tumor in the intestinal tract called argentaphin cells. So we know with melanuria, it's from melanoma. This is the argentaphin cells in the intestinal tract. There's a tumor. And there's excess amount of serotonin, which results, so if you see 5-hydroxytryptophan, when there's a malignant tumor, produces excess serotonin, which then breaks into 5-HIAA. You don't have to know the 5-hydroxyindoleacetic acid. You just have to know 5-HIAA. Okay? So you have two tumors, melanuria, the excess melanin because of the melanoma, and here you have excess 5-HIAA due to the tumor on the argentaphin cells in the pancreas. What is the pathway for both of these? Tryptophan. So you already know you're going to have a matching with certain disorders and what amino acid pathway. And those would be the two major pathways I flag. So it might help you even next to phenylalanine tyrosine. You might want to write PKU, melanuria, and alkaptonuria. And you know those all go with that pathway. So PKU, melanuria, and alkaptonuria. Flag them some way. And then down here, the two that are involved with the tryptophan pathway, Hartnups, and what's its classic feature? The blue baby's diaper, when that indican turns blue when it's exposed to air. And then the 5-HIA, the tumor. So those are all tryptophan. Those are the pathway ones I'm going to ask you, okay? And then what is the common treatment? Other than the tumors, naturally you're going to have to do chemotherapy and see if that helps at all. Melanoma is tough. If a melanoma, the best case I've heard, my girlfriend had it, that her gynecologist saw a spot on her leg, and this going on 15 years ago. And we were playing volleyball, and she said, Jean, look at the spot. My doctor wants me to have to go to the plastic surgeon and have it removed. Because on cancers, they got to do like a 2-inch exite, they call it an X-out, around the spot. And it was like a freckle. And they had to go around that wide on her thigh. And then they pull it all together, and she has this fine line that's probably 2 to 3 inches on her leg. And it was very superficial. She never had to have any chemo, nothing, and it's 15 years later, not having a problem. My daughter's girlfriend's dad, he was, probably in his 40s, had a melanoma on his back, but it was invasive into the tissues, and he died in 3 years. Melanoma, if it's invasive, is very, very tough to treat. So that one, the argentaphin one, then is going to have the excess serotonin with the 5-HIAA. But usually on the amino acid disorders, the treatment is dietary changes. And the problem for all of them is mental retardation if it's not caught early enough. So you see, if someone doesn't have any prenatal care, any good aftercare, how you could see children have problems, and it's all because they didn't get good care initially. And then these, they don't really have anything that they relate, so we're going to pick out key things. Because you got to know the key things, not just for me, but for the registry. These are the last three. One are called mucopolysaccharide disorders. You have connective tissue that has polysaccharide in it. And normally these people have abnormal skeletal features. And they have an inherited defect that they can't break down these polysaccharides. All I want you to know, I would underline excess polysaccharide into the connective tissue so it relates to skeletal structure. So when you talk about autoimmune disorders with Diane, connective tissue is a big thing that's affected, your joint pain and inflammation. So they're called mucopolysaccharide. And you got to just know Hunter's, Hurler's, Sanfilippo. I'm sure they're the three people that discovered whichever one they discovered of each of the three. That's all you got to know for me. It's a problem with breaking down the polysaccharides in connective tissue, which causes skeletal problems, the structure. And then Hunter's, Hurler's, Sanfilippo. This one you guys already know. We already talked about that one. But purine disorders. uric acid builds up in a disease called Lesch-Nyhan. And not only can it cause mental retardation, gout is associated with it, and sometimes the uric acid, which is one of our acid crystals, can form a kidney stone. That's what the renal calculi is. So all you gotta know, a purine problem is excess uric acid. They call the disease Lesch-Nyhan. And you should always know excess uric acid can lead to gout. So we know the metabolism problems lead to mental retardation, but I would also know uric acid in relation to gout, okay? And it is one of our urine acid crystals, so anything crystal form in your urine can precipitate out and form a kidney stone, if enough. And then you already know if you don't have glucose as your problem, you as a tech, negative glucose on the dipstick, positive clinitest, and you would have to have a policy in your urinalysis department that any urine on a child less than 2 years of age, you do a clinitest. Otherwise, are you going to detect it? No, because you wouldn't be doing the clinitest. So we're going to keep our lab as any patient less than 2 has to have a clinitest, even if their glucose is negative. So that's what we mean by a carbohydrate disorder. Normally we talked about excess lactose or galactose. Okay, so let's recap. This is for next week's test, nothing to do with this week. So we already know the phenylalanine, tyrosine, name the 3. PKU, alkaptonuria, melanuria. The key finding with the last 2 were urine darkens upon standing. So you as a tech, that may be the only piece you ever see. Then the tryptophan pathway, name the 2. Hardnups disease, the blue baby diaper syndrome, and the tumor, 5-HIAA. The other tumor was the melanoma with the melanuria. Okay, name the branch chain maple syrup sugar disease. We know the big clue is the maple syrup odor if you were doing a urine. What are the amino acids? Leucine, isoleucine, and then valine. And then name the 3 that involve the connective tissue and your skeletal structure. Sanfilippo, Hunter's, Hurler's. And then name the one with excess uric acid, and it might lead to gout, renal stones, mental retardation, the Lesch-Nyhan. And then you already know a carbohydrate disorder would have a negative dipstick glucose and a positive clinitest. And then what else am I missing? It seemed like there was something else in the middle. Oh, name the one that is caused by a kidney defect. Nothing to do with something genetic. Cystinuria, and that is the kidney's inability to reabsorb the cysteine, and there were other amino acids, and then it could form a kidney stone as well with the cysteine, and that was the hexagon shape. Okay, so what we're going to do, I got the 6 urines again from Urgicare. I'm going to do Urgicare this week, and then next week, since I need to start looking for body fluids, I'm going to go back to the hospital because they don't do body fluids at Urgicare. So what we're going to do today, we're going to do, so Tiana, if you give your urine again, me, you give my urine again. Can you get your dad's urine sometime?
Yeah, I can try and get it tomorrow.
Try to bring it for tomorrow so we can look at it under the microscope too.
Yeah.
Plus to test his sugar. And then if anybody else, and I'll do mine. And we'll at least do one good one under the microscope. One looks like it might have amorphous, but we're going to at least look at it because she had to take from both days. She was nice enough to take the time and find the results, and then I already put them on a sheet. So, and I already copied them from you. So we're going to do pairs again to come up with the results of the microscopic. This time in your syllabus, I put it on the wrong sheet. You're going to have to put your microscopic on one of the microscopic sheets. In your syllabus, there's one that says just microscopics. I don't know if they're past 105, 106. So you want one of them at least. And everybody has to get 4 urines done today. I'm hoping 4 on your own plus the 1 we do before we break for lunch. So this is, tomorrow we're gonna do 4 urines and start doing a manual red and white count on a spinal fluid. Because I can doctor those up with Buffy coats from Purple Tops and they work really well. So tomorrow's lecture we're gonna focus on body fluid counts and how to use that formula. So tomorrow will be like a review of doing the manual red and white, which we should be pretty good at. And that next week then, we'll start with the body fluids first, then end with our urines. Tomorrow we'll start with the urines first, then do a body fluid. Because, and I gotta tell you something that came up at our meeting. They say our students they're more robotic about running one machine. So we were thinking I said, we have it a little tougher than they do because we might have 12 students trying to use an hour and 50-minute lab period. They have 1 student for 8 hours a day. So we asked them if when you get to the end of your rotation, they would make you go back and do something from every department as a practical. Not just, okay, you ended in heme, you do a heme practical. What we're gonna do, since I'm taking already part of the 2 longest tests for Diane's serology, when I teach you the code agglutinin today and the RF tube test for rheumatoid arthritis tomorrow, I'm already gonna end with a little practical on those 2. So Diane never has to worry about doing that. So her serology practical, we're gonna add probably a ProTime, a CBC on the analyzer. We'll probably do a manual chemistry test. We'll do a UA and we'll do serology. So I told him in my advisory meeting minutes that we on our end are gonna try to make you get the whole picture and do everything you've learned since last spring. Because they're saying our students, if they don't train them as a student and then hire them, they're saying they're like, oh my gosh, they can't critically think. So we're both on each end. So when I go review the syllabus starting next week with every clinical, I'm gonna ask them as your final day, let you practice on Wednesday, and on Thursday let you do all areas. Because they're saying students are, oh no, I don't know what to do now. You know, even though they've had it, they don't know how to relate everything together. So we're gonna try to attack it. That's gonna be my main improvement for next year. By the time you guys get done in May, that you guys critically think better about the whole process. And that came directly from them. I mean, one of the hospitals had 2 students trained at another hospital and they had never trained them, and they let both of them go after 6 weeks because they could not develop multitasking. And so I take very seriously anything they say to me because I want them to hire our students. So I told, I let them know we're gonna try something with you guys just to see if we can try to get you thinking and pulling it all together. Because it is tough. You guys are taking so much in and you're so new, it's tough to get that. But maybe if we do a little bit here, when you go there, it won't be so scary to you. Anyway, so we'll start and then we will